It's an 8x10. And after I get my tube set up, I'm going to then ask for assistance in holding the IR. So for the set of gas, I'm going to bring the tube pretty much to its limit because I'm going to be shooting up through the interspace between his patella and his femur into fib. So I'm going to go ahead and bring this down all the way. I'm going to move him cable out of the way so I can get it that low. I'm going to angle the tube up. I'm going to bring it all the way down.
The angle usually ends up being...
Usually it's about 15 degrees. The tube usually reads 115 degrees. So then I'm going to turn on my collimator. I'm going to turn on my collimator and I'm going to see the line, and the central ray should go directly through that patellofemoral joint. So, sir, would you go ahead and mind holding this? You're just going to be right there. So what I want is the angle of the tube to match the angle of this IR. So that means that the central ray goes through the patella. The patella should be perpendicular to the IR. So I'm going to collimate in so that I just get this area of the patella and I don't shoot a bunch of x-ray into the room. So I'm going to put my right marker on, out of the anatomy, of course, and I'm going to change my technique to about 65 at 3 max. Okay, so now I'm going to shield him, and now for this one, since the central ray is pointing up, I'm just going to go ahead and put that on this side, okay, sir? Don't, try not to move. Okay, so I'm just going to make sure that I have, go ahead and push me in. I want to make sure that everything's still aligned. We're perfect, so I'm going to shoot it out of a... Yeah, you're just going to go ahead and hold that. Good, I'm glad you caught that. Okay, so I put my right marker on. I'm going to go ahead and leave the room and shoot the x-ray. Cha-ching! Okay, great. Go ahead and give me that. Thank you very much. Yeah, let her relax. I'm going to go run this. Okay, now while that's running, we're going to do our last x-ray. You're doing a great job. Okay, so this one is the intercondylar fossa. This is an axial shot. So I'm just going to put some support underneath your knee here. Okay, could you go ahead and lift up your right foot? Great, thank you. Okay, now I'm just gonna put this right arm, and have you hold it in a minute. So for this one, the Buckler, see the intercondylar fossa, we're gonna have to get the central ray's angle to match the angle of his femur. So we're going to bring our tube up. We're going to angle it all around here. Okay. I still want my SID to be about 40 inches, which I'm at. Okay. So now I'm going to get it to match the angle of the femur. So what we want is this angle here to be 60 degrees. And then I want this angle here to be 30 degrees. And I want to shoot, once again, through the patellofemoral joint so that we image the intercondylar fossa onto the IR. So what I'm going to do is put my IR here. And once again, I'm going to center ½ an inch below the patellar apex. And now I have my SID at 40. I have the IR built up as much as possible. And I have my tube angled to match, to be perpendicular to the tip. Okay, great.
The long axis.
So you can go ahead. I'm just going to put this here, and you can go ahead and hold that there. That'd be great. I'm going to put my right marker on to my set out of the anatomy, and I'm going to change my technique at 4 mass. You can go ahead and just breathe normally. Just don't move, please. And I'm going to go outside the room and take the x-ray. Cha-ching. Okay, so, sir, I'm just going to go ahead and check this one last x-ray with this one last picture. You just go ahead and hang tight there. I'll be right back. I'm going to move this out of your way.
And after
Shield.
I decide that it's a good x-ray, I'm going to Dicom
Okay,
it.
so I'm just going to go ahead and check this. I'm putting it into my Fuji, and I'm waiting for my last x-ray to come up. Now I've checked everything, and I have all my anatomy that I needed. Everything is properly centered and collimated.
Make sure that I put in props.
I'm going to let you go. You're all set. I'm just going to remove this. I'll lower the table back down.
And then I'll show him back to his dressing room. And after he's gone, I'll make sure that I put in all the props, all of his information, and I'll send it off to the doctor when I'm done with that. And the doctor and the PAC system and such as that. Now, we're going to talk about the criteria for all those x-rays that we shot.
Hi. So, when I left the room to go check the x-rays before I let my rather kooky patient go, i.e. Darren Taylor, I checked the x-rays for certain criterion that make them a good diagnostic value. So, I would bring up something like this on the monitor and check it for certain criteria. So what I'm looking for is good inspiration, first
On a
of all.
PHS.
So I want to see anywhere from 8 to 10 ribs, or in that range, 8 to 10 ribs. So 1, 2, 3, 4, 5, 6, 7, 8. I'm also looking for no rotation, so it's equidistant between the spinal cord and the clavicle and such. I'm also making sure that all the anatomy is included. So from the apices of the lungs to the both costophrenic angles, and making sure that none of that was clipped off. Okay? And I'm also looking to make sure that the scapulae have been rotated so that they're out of the lung fields. And then my last thing I'm looking for is...
On a good PHS.
Oh, shoot.
Is I want to make sure that the spine is through the heart shadow,
Is
of
my
course.
spine through my heart shadow, of course.
Well, Darren.
So that would be a good PA chest image. So next I would pull up my lateral chest, which would be something along the lines of this, if you can see it. I don't know where I am on this. There we go. Something along the lines of that. Now when I'm looking at the lateral chest image, I'm making sure that the ribs are superimposed, that the intervertebral joint spaces are clearly open. I'm also making sure that the sternum is in a lateral position. And again, all the anatomy is included, so from the apices to the costophrenic angles. And like I was saying while I was doing the exam, the hilum should be in the center of the image. And also that the patient should not be leaning backwards or forward. That is, mid-sagittal plane should be vertical. And that's a good lateral chest x-ray image.
Which is always shot in portrait, not crosswise, which I accidentally misspoke earlier. I guess you can't misspeak on purpose, so yes.
Now, for my AP right knee and my lateral right knee, I am
going to pull up something a bit like this. You can see the AP there on the right of your screen and the lateral on the left of your screen.
Invert
now,
that.
if you look at these in the AP, you can see the the femur and tibia are seen without rotation. You also see the femoral tibial joint space, the proximal joint space is open. The head of the fibula is slightly, the proximal tibia is slightly superimposed on the head of the fibula. The patella is completely superimposed on the distal portion of the femur. And in a normal knee x-ray, the femorotibial joint space should be equal on both sides. So, and then on my
Equal amount of space.
lateral knee, the femoral condyle should be superimposed. The patella should be projected in profile, which it is. Once again, the femoral tibial joint space is open, and the fibular head and the tibia are slightly superimposed. So that's what I was looking for when I made sure that I had, as I said to him, everything on the image. Hi, so next up is the internal oblique knee. And here I would pull up an image a bit like this. So on this x-ray, I'm looking for the lateral condyles of the femur and the tibia should be visualized. The knee joint space should be open. The medial margin of the patella should be slightly beyond the medial margin of the femur. And the tibia and fibula should be separated at their proximal articulation. So that's what I'm looking for on the medial oblique x-ray, and that's actually what the medial oblique x-ray is for, to show the fibular head free of superimposition.
Almost free. And that was a bit contrasty at first, but you could see later that it was just pulled up a little bit in the dark.
So the next image I took on Darren was a tangential patella, the Settegast method, otherwise known as the sunrise, and that would look something a bit like this. So on this, what I'm looking for is that the patellofemoral joint space should be clearly open, i.e. like the sun coming up over the mountains. The patella is seen in profile on this x-ray, and the femoral condyles are both visualized, and that is a good sunrise, i.e. Settegast method shot patella.
And we're almost done, folks. Almost to the finish line. I hope you're getting a good laugh out of my editing and such.
Now, the last x-ray I shot on poor beat up Darren, was of the intercondylar fossa. Now, I used the Beclaire method, which required building up the IR because it was shot AP instead of PA like the Holmblad and Coventry methods. So the x-ray would look a bit like this. The only difference maybe with a bit more femur in the picture, maybe a bit more tibia and fibula as well. So the criteria for this x-ray is that the fossa should be open and visualized, which it is. The apex of the patella should not be projected into the fossa, which it is not. The posterior surface of the femoral condyles should be visualized, which of course they are, and the legs should not be rotated, as you can see here by this slight superimposition of the tibia